We'll be breaking down all major concepts covered on the exam. Because, on the MCCQE, if you just prescribe a standard acne medication to the wrong patient, it might not just fail to clear their skin. It could actually trigger dangerous systemic hyperkalemia or even exacerbate a hidden hormone-secreting tumor.
Right. And when you are sitting there taking the exam, you really need to understand that the test makers, well, they aren't just checking if you know what a normal breakout looks like.
Yeah, totally.
They are actively testing your ability to see the underlying structural mechanisms, to instantly spot those clinical red flags hidden in a patient vignette, and of course, to execute a really highly specific stepwise management plan.
Exactly. So welcome to the deep dive. I'm Harvey, and alongside me is Donna. We are expert MCCQE reviewers, and our singular goal today is to help Canadian medical students feel perfectly comfortable, confident, and totally ready for whatever the S10 dermatology section throws at you.
Yes, absolutely. And before we get into the clinical weeds of our primary focus today, which is Acneiform eruptions, and specifically Acne vulgaris, we do need to state our standard disclaimer.
Right, the legal stuff.
Exactly. The information in this deep dive is drawn directly from reliable StatPearls articles and is strictly for medical education, not medical advice. Clinical decisions in the real world must always involve a qualified healthcare provider.
All right, so let's get into it. Our mission today is to provide you with a really clear, efficient clinical breakdown of the presentations, the management algorithms, and most importantly, those high-yield MCCQE traps that the examiners just love to use.
They really do love them.
They do. Because to actually get those management questions right, you can't just memorize a list of drug names. You have to visualize the structural failure happening inside the skin first. So let's start at the microscopic level. Fundamentally, what is actually happening to the tissue in acne vulgaris?
Well, at its core, acne vulgaris is a chronic inflammatory disorder of the pilosebaceous unit.
Okay, the pilosebaceous unit.
Right. That's essentially the hair follicle and its associated sebaceous gland. And there's this cascade of 4 primary pathogenic events. If you can, picture this cascade happening in real time, the entire treatment algorithm we discuss later is going to make perfect logical sense.
Awesome. So what's step 1?
It starts with the accumulation of keratinous material down in the lower region of the follicular infundibulum.
And the literature calls this microscopic structure a microcomedo.
Right, exactly. It's essentially just a plug.
A plug, okay.
Yeah, the skin cells inside the follicle, the keratinocytes, they aren't shedding normally. They sort of stick together, forming this hyperkeratotic mass. And this microcomedo is literally the precursor to absolutely all other lesions in acne.
Wow, all of them. But I mean, a plug alone doesn't cause the massive inflammation we see clinically. That requires the sebaceous gland to get involved.
Right, which brings in the androgens.
Right.
During puberty, or just due to normal hormonal shifts, the sebaceous glands start ramping up sebum production.
Sebum being the oil.
Exactly. But here is a very critical concept for the exam. The vast majority of your acne patients do not have abnormal hormone levels. Their circulating androgens are actually completely normal.
Let's really highlight that for everyone listening because the exam loves to trick you into ordering unnecessary hormone panels.
Oh, all the time.
Yeah. So the pathology here is usually the hypersensitivity of the sebaceous gland to those normal androgen levels. The gland just overreacts to a normal stimulus and pumps out massive amounts of sebum.
Right. And that excess sebum gets trapped behind that microcomedo plug we just talked about. So you now have a closed, oxygen-deprived, lipid-rich environment.
Which sounds like a recipe for disaster.
It is. It's the perfect breeding ground for Cutibacterium acnes, or C. acnes. Now, this is a commensal bacterium, meaning it normally lives peacefully on our skin.
But not when it's trapped.
Exactly. Trapped inside this sebum-filled balloon, it just rapidly proliferates. In fact, the StatPearls sources even point out a specific division of this bacteria, an epidemic clone known as Phylotype Ia.
Phylotype Ia.
Yeah, and that specific strain is highly associated with moderate to severe acne.
Okay, so you have a blocked tube, rapidly filling with oil, and bacteria is just multiplying inside it. That pressure builds and builds until the follicle wall simply gives out. It just ruptures.
Right. And the rupture is the final pathogenic event, which is inflammation. All that trapped bacteria, keratin, and those pro-inflammatory lipids spill directly into the surrounding dermis.
And the body does not like that.
Not at all. The immune system detects this debris where it shouldn't be, and it triggers both innate and adaptive immune responses. Neutrophils rush in, and that massive inflammatory response is exactly what creates those deep, painful nodules you see on the surface.
I always like to visualize this for the exam like a house's plumbing system.
Oh, that's a good way to look at it.
Right. So the microcomedo is the clump of hair and soap clogging the drain. The hypersensitive sebaceous gland is like a broken faucet stuck on maximum, constantly filling the sink with water.
Right.
And the C. acnes is the bacteria festering in that stagnant, standing water. And then that final stage, the deep nodule. That is the pipe violently bursting behind the drywall because it couldn't handle the pressure.
That analogy holds up perfectly, especially when we get to pharmacology, because, you'll see that every single treatment we prescribe acts as a specific tool to fix one part of that plumbing disaster.
Exactly. But before we prescribe anything, we have to recognize what this actually looks like when the patient walks into the clinic.
For sure. Tracking that burst pipe mechanism makes interpreting the physical exam much easier. The exam vignettes will often describe the evolution of lesions. So the microcomedones are subclinical, meaning you can't even see them.
Right.
But as sebum and keratin accumulate, that microscopic plug expands into a closed comedo.
And visually, that's your classic whitehead, right?
Right.
Like a small flesh-colored papule.
Exactly. Now, if that follicular orifice continues to distend and eventually dilates, exposing the plug to the surface, it becomes an open comedo.
Commonly known as a blackhead. And if you have a patient asking you about this or a clinical vignette testing patient education, you really have to dispel a common myth here. Blackheads are not dark because they are filled with trapped dirt.
Definitely not dirt.
Yeah. The dark color is strictly due to the oxidation of lipids and the presence of melanin within the comedo as it hits the air.
Yep. From there, if the C. acnes proliferation and the immune response escalate, the vignette will describe inflammatory papules and pustules.
The red, angry pimples.
Exactly. And finally, if the follicle wall undergoes that catastrophic rupture into the deeper dermis, the presentation upgrades to severe, painful nodules.
And when you're reading the clinical distribution on the exam, you're looking for these lesions on the face, neck, chest, and upper back.
Right.
Because those are the areas heavily populated with those hormonally responsive sebaceous glands. But hold on, let me pump the brakes and put myself in the shoes of a test taker for a second.
Yeah.
If I'm reading a vignette about a patient who comes in with, massive, painful, ulcerative nodules on their back, these things look incredibly severe.
Okay, yeah.
My clinical instinct, especially in a high-stress exam setting, is going to scream at me to biopsy that immediately. To rule out a severe staph infection or MRSA or even maybe a cutaneous malignancy. Are you saying the MCCQE will penalize me for selecting the biopsy option?
Yes. You will absolutely lose points for that.
Wait, really?
Yes. The diagnosis of acne vulgaris is strictly clinical. It is a physical exam diagnosis based entirely on the visual polymorphism of the lesions, seeing a mix of comedones, papules, and pustules.
So no biopsy at all?
Exactly. The exam will almost never want you to biopsy standard acneiform lesions. It is a classic distractor.
Okay, so no skin biopsies. Got it. But that doesn't mean we just throw some cream at every patient and send them home. While the acne itself is a clinical diagnosis, the exam absolutely expects you to recognize when the acne is acting as a siren for a much more dangerous systemic issue.
Yes, those are the red flags, and they are incredibly high yield for the MCCQE. Let's run through how these will actually look in a test question.
Sounds good.
Imagine a 25-year-old female patient comes in. Her chief complaint is severe acne along her jawline and lower face that has been completely unresponsive to over-the-counter washes.
Okay.
But the exam subtly mentions in her history that she has highly irregular menstrual periods. And on physical exam, you note some excess facial hair, so hirsutism, and a dark, velvety patch of skin on the back of her neck.
Ooh, the acanthosis nigricans.
Yeah.
If your hand is hovering over the prescribed topical retinoid button, you need to stop right there and look at the systemic picture.
Exactly.
That is a textbook presentation for polycystic ovarian syndrome, or PCOS. And the exam doesn't just want you to recognize this syndrome, it wants you to know exactly which labs to order to confirm the underlying hyperandrogenism.
Right. For that patient, you need to select the option to check total and free testosterone, luteinizing hormone, follicle-stimulating hormone, and dehydroepiandrosterone sulfate, or DHEA at best. You basically have to prove the hormonal imbalance before you can effectively treat her skin.
Okay, let's look at another scenario. Say a patient presents with a sudden explosive onset of severe recalcitrant acne. We're talking massive cystic breakouts over a matter of weeks, and they have absolutely no prior history of significant skin issues.
And let me guess, they aren't a teenager.
Nope, they're in their late 20s or 30s.
Yeah, that rapid, severe onset in an adult is a massive red flag. Standard glandular hypersensitivity doesn't just switch on overnight like that. You need to immediately suspect an androgen-secreting tumor.
Like ovarian or adrenal in origin.
Right. The exam wants you to initiate a laboratory workup and imaging to hunt for a neoplasm, not just schedule a follow-up for a dermatology consult.
And there's one more critical systemic trap. Let's say a young patient, usually a teenage male, presents with severe, sudden ulcerative acne on the trunk. But the vignette adds that he has a fever of 39 degrees Celsius, severe myalgia, and bone pain in his clavicle or sternum.
Oh, that presentation is acne fulminans. It is a severe, explosive, systemic inflammatory response.
So what's the move there?
The exam wants you to investigate the systemic involvement before you even think about the dermatological treatment. You are ordering a complete blood count to look for leukocytosis, liver function tests, and inflammatory markers like an erythrocyte sedimentation rate and C-reactive protein. You might even need radiographs to check for osteolytic lesions where they have bone pain.
Wow. So when you are in the exam room, those are the scenarios that require a major systemic detour. But once you've successfully navigated those traps, ruled out the tumors, the PCOS, the systemic inflammation, and you've confirmed a typical acne presentation, the exam is going to test your stepwise management.
And the algorithm always starts with mild cases.
Right. To treat it correctly, we first have to define it. Mild acne means the patient has scattered comedones or a few small inflammatory papules. Crucially, there is no scarring, and there is an absolute absence of nodules or confluence of lesions.
Exactly. And for mild cases, our treatment approach is entirely topical. The MVP, the foundation of almost every acne regimen, is the topical retinoid.
We're talking about medications like tretinoin, adapalene, and trifarotene. But how did these actually fix our plumbing issue?
Well, they are vitamin A derivatives, and they work deep at the cellular level. They enter the keratinocytes and bind to specific receptors in the nucleus. The retinoic acid receptors, or RRs, and retinoid X receptors, RXRs.
Okay, so they bind to the nucleus, then what?
Once they bind, they alter gene transcription to normalize follicular keratinization. Essentially, they just reduce the cohesiveness of the skin cells, allowing them to shed normally instead of clumping together.
Ah, so they are the chemical drain snake.
I like that. Yes.
They prevent that keratinous microcomedo from forming in the first place, keeping the pipe completely clear. And because they prevent the precursor lesion, the exam wants you to know that retinoids are recommended for long-term maintenance therapy, even after the active acne has completely cleared up.
That's right. Now, alongside the retinoid, we frequently employ benzoyl peroxide, or BP.
BP is everywhere.
It really is, and it's a dual-action agent. It has comedоlytic properties to help break down the plugs, and it is a potent antimicrobial against C. acnes. It releases these free oxygen radicals that just destroy the bacteria's cell walls.
But there is a very classic, highly tested interaction between BP and certain retinoids, isn't there?
Yes. This is huge for the exam. Think of benzoyl peroxide like bleach.
Okay.
And tretinoin like a delicate silk fabric. If you put them in the washing machine at the exact same time, the bleach destroys the fabric. Benzoyl peroxide has a strong oxidizing effect, and if applied simultaneously with standard tretinoin, it will literally oxidize the retinoid, rendering it completely chemically inactive.
So you're basically rubbing useless cream on your face.
Exactly. So the exam will test your patient counseling on this. You must advise the patient to apply the benzoyl peroxide in the morning and the tretinoin in the evening. Now, some newer formulations, like the microsphere formulation of tretinoin or adapalene, are actually stable with DT, but the separation rule is standard clinical wisdom the MCCQE loves to verify.
Right, keep them separated. And there is another major behavioral trap here regarding where to apply the retinoid. Patients invariably want to use it as a spot treatment.
Oh, always.
They see a massive pimple on their forehead, they dab a huge glob of tretinoin directly onto it, and they just ignore the rest of their face.
And you will be tested on correcting that behavior. Remember the cellular mechanism. The entire goal is to prevent future invisible microcomedones from forming. If a patient only spot treats active lesions, they are just constantly chasing the disease. You must counsel them to apply a thin layer to the entire affected area, the whole face, chest, or back.
But, I mean, the moment you tell a patient to cover their whole face in tretinoin, they usually come back 3 days later furious because their skin is red, peeling, and burning.
Right. The irritation is a known, expected side effect.
So how do the guidelines want us to manage this so the patient doesn't just abandon a highly effective first-line therapy?
It's all about dose control and frequency escalation. You counsel them to use a pea-sized amount, literally a single pea for the entire face.
That's tiny.
It is, but it's enough. To build tolerance, you have them start applying it every other night, or even every third night. And you must ensure their skin is bone dry before application because moisture actually increases absorption and irritation.
Oh, that's a great tip. And for the exceptionally sensitive patients, the exam might offer short contact therapy as an option, right?
Yes. This is where they apply a retinoid like tazarotene for just up to 5 minutes daily and then immediately wash it off. It gives a therapeutic effect while drastically minimizing the contact time and subsequent erythema.
Awesome. Now, we also need to talk about topical antibiotics like clindamycin or erythromycin, because there is an absolute non-negotiable rule on the exam regarding these.
Never, ever prescribe them as monotherapy.
Ever. Using a topical antibiotic alone is a guaranteed way to breed resistant strains of C. acnes. The guidelines are super strict. If you use a topical antibiotic, it must always be combined with benzoyl peroxide.
Because the antimicrobial mechanism of BP doesn't induce bacterial resistance, so it acts as a safeguard.
Exactly. You might also see azelaic acid as a topical option. It is a dicarboxylic acid that is both antimicrobial and comedolatic.
But its true superpower for the exam is that it acts as a competitive inhibitor of the tyrosinase enzyme.
Tyrosinase being essential for melanin production.
Right. So if a patient has coexistent post-acne hyperpigmentation, azelaic acid is a brilliant dual-action choice to clear the acne and fade the dark spots.
Okay, so we've optimized the topicals. But what happens when the faucet is just stuck on maximum? What if a patient walks in and the topicals haven't made a dent? They have multiple deep nodules, severe inflammation, and maybe early signs of scarring.
The clinical stakes are much higher here, and the exam expects you to step up the intensity to systemic therapies. This is moderate to severe territory.
Which means we are seeing large inflammatory papules, pustules, deep nodules, and scarring.
And it's important to note that this category also includes cases that might look physically moderate but are causing severe, debilitating psychological distress to the patient.
Right, so the first-line systemic intervention is oral antibiotics, specifically the tetracycline class. So doxycycline, minocycline, and the newer sarecycline.
And we aren't just using them to kill bacteria. These drugs have distinct, potent anti-inflammatory properties right down at the follicular level.
But you cannot leave a patient on them indefinitely. The guidelines cap their use at 3 to 4 months maximum to prevent systemic antibiotic resistance and microbiome disruption.
Exactly. You always use a topical retinoid concurrently, so that when you withdraw the oral antibiotic, the retinoid just maintains the clearance.
But for the MCCQE, knowing the drugs isn't enough, you have to know their adverse effects cold.
Oh, for sure. The classic board-relevant side effect for tetracyclines is tooth discoloration and interference with bone growth. They readily bind to calcium ions in developing teeth and bones.
Therefore, you absolutely must avoid prescribing them to pregnant women and children under the age of 8.
They are also notorious for causing severe gastrointestinal distress and piloesophagitis. You have to counsel the patient to take them with a full glass of water and remain completely upright for at least 30 minutes afterward.
Right, no lying down. And they also cause significant photosensitivity, meaning the patient will severely sunburn if they aren't meticulous with SPF.
And then there is the rare but terrifying neurological side effect, pseudotumor cerebri, also known as idiopathic intracranial hypertension.
Ah, yes. If you have a patient who has been on doxycycline for a month, and they suddenly present to the clinic complaining of a severe new onset headache, maybe pulsal tinnitus, and blurry vision.
That is your exam alarm bell right there. You must immediately discontinue the medication and evaluate for papilledema.
Okay, let's shift gears to a systemic approach tailored specifically for female patients whose acne is deeply tied to their hormonal cycle. Spironolactone is a major player here.
It is. It's an oral anti-androgen. Mechanistically, it blocks androgen receptors on the sebaceous gland, but it also inhibits androgen synthesis. It specifically decreases the activity of 17-beta-hydroxysteroid dehydrogenase, which is an enzyme in the skin that converts weaker androgens into highly potent testosterone.
So it literally turns off the internal faucet at the source. The sebaceous gland just stops pumping out oil, with sebum secretion dropping by up to 50%.
But spironolactone wasn't originally designed as an acne medication, was it?
No, it wasn't. It is fundamentally a potassium-sparing diuretic. It works by blocking aldosterone in the kidneys. Normally, aldosterone causes the kidneys to excrete potassium. If you block it, the body holds onto that potassium.
Right, and because of that mechanism, the key lab value you absolutely must monitor is potassium. You have to watch closely for hyperkalemia, especially if the patient is on other medications affecting renal function. You also need to warn them about potential menstrual irregularities and breast tenderness.
Now, to counteract those menstrual irregularities, spironolactone is frequently paired with combined oral contraceptives. These pills increase sex hormone-binding globulin, which sweeps up free testosterone in the blood, further clearing the acne.
But here is a very specific, high-yield MCCQE trap. Imagine a 22-year-old female patient comes in complaining that her acne exploded and got significantly worse 2 months after she started a new birth control pill prescribed by another clinic.
Oh, this is a tricky one. The exam is testing your knowledge of progestin-only pills. Certain contraceptives, like the mini pill or hormonal IUDs, contain highly androgenic progestins like norethindrone or levonorgestrel.
And because they lack estrogen, they have a net androgenic effect and will actively exacerbate acne vulgaris.
So if Vivienne describes a patient whose acne flared on a new contraceptive, your clinical reflex must be to check if it is a progestin-only method. The exam wants you to recognize that only specific combined oral contraceptives, the ones containing both estrogen and an approved progestin, are FDA-approved and effective for treating acne.
Right, which brings us to the absolute heavy hitter of acne management, oral isotretinoin. This is reserved for severe, recalcitrant, nodular acne that is actively causing scarring or acne that has just failed all other systemic therapies.
It is the ultimate weapon. Think of it like a massive fire extinguisher that just eliminates everything the fire needs to survive. It is the only medication that directly combats all 4 of the pathogenic factors we discussed earlier.
It really does it all.
It does. It radically normalizes keratin shedding, breaking down the microcomedones. It dramatically shrinks the sebaceous glands and shuts down sebum production. And by removing the lipid-rich sebum, it starves the C. acnes bacteria, and subsequently the massive inflammation halts entirely.
But with great pharmacological power comes immense clinical responsibility, and the exam will test your adherence to the rules here. Oral isotretinoin is a potent teratogen. It causes severe, catastrophic birth defects.
You cannot prescribe or dispense it without absolute adherence to strict risk management protocols, like the IPL-DGEJ program. If the exam vignette involves a female patient of childbearing potential, you must secure 2 negative pregnancy tests before initiating therapy.
And mandate monthly pregnancy tests thereafter.
Exactly. Furthermore, they must be using 2 forms of contraception, and they must be explicitly counseled to discontinue the medication at least 1 month before even attempting to conceive, allowing the drug to fully clear their system.
And the monitoring doesn't stop at pregnancy. You must regularly check liver function tests and fasting lipid panels. Isotretinoin can cause significant hepatic transaminase elevation and severe hypertriglyceridemia.
In a small but vital detail the exam might throw in, patients are strictly prohibited from donating blood while on the medication, and for a month after, just to prevent exposing a pregnant transfusion recipient to the teratogen.
That's a great point. Now, as we wrap up the clinical management, we have to look past the active breakouts and examine the long-term aftermath of the disease. Because for the patients sitting in your clinic, the story absolutely does not end when the inflammatory papules finally fade. The MCCQE expects you to anticipate, recognize, and manage the long-term complications.
Yeah, the most permanent and physically altering complication is scarring, which results from the profound destruction of dermal collagen during that explosive inflammatory phase. And the exam might use highly specific descriptive terms that you need to recognize.
Like what?
So, depressed scars can present as wide, oval craters known as boxcar scars. They can be deep, narrow, sharply demarcated pits called ice pick scars, or they can be broader, undulating depressions with sloped edges known as rolling scars.
And depending on the patient's genetics, the abnormal healing can also lead to raised hypertrophic or keloidal scars.
Right. Another incredibly distressing complication is post-inflammatory hyperpigmentation, or PIH. Even after the acne is gone, these flat, dark macules remain. The StatPearls sources explicitly note that this complication is exceptionally common and pronounced in individuals with darker skin tones, specifically Fitzpatrick skin phototypes 4A to 6.
Which means treating the active acne early and aggressively in these populations is critical to preventing months or even years of PIH.
Exactly, which perfectly transitions to the profound psychosocial impact of this disease. Acne is not simply a cosmetic annoyance. The literature strongly links moderate to severe acne with significant lasting increases in clinical anxiety, depression, social withdrawal, and even suicidal ideation, particularly in adolescence.
That is so important to remember.
If you see a vignette describing a teenager who is refusing to attend school or dropping out of sports because of their skin, the exam is telling you that aggressive, effective treatment isn't a cosmetic luxury. It is the absolute medical standard of care. You are treating their mental health just as much as their epidermis.
Right. When you are taking the MCCQE, you really have to trust your clinical judgment. Rely on that clear stepwise algorithm. Start with topicals for mild cases, step up to systemics for moderate to severe, and always keep a vigilant eye out for those hormonal and systemic red flags.
If you understand the mechanisms, the exam questions won't feel like random trivia. They will feel like logical clinical puzzles.
Absolutely.
Before we close out this deep dive, I want to leave you with a truly fascinating epidemiological nugget drawn from the StatPearls text. It profoundly highlights that acne might not just be an isolated superficial skin event. A large Swedish study observed a potential association between teenage boys who suffered from severe acne and an increased risk of developing prostate cancer much later in their adult lives.
Wow, that's a striking correlation. It really forces you to think about the broader implications of glandular hypersensitivity.
Right. What does that tell us about the long-term systemic footprints of androgen sensitivities? The things we so casually dismiss in the clinic as just an awkward teen phase might actually be leaving a much longer systemic trail than we ever realized. Keep that broad investigative perspective in mind the next time you're evaluating what seems like a simple clogged pipe. See you next time on The Deep Dive.